in this industry, if it wasn't documented, it wasn't done. And so we need to show in every instance that we've provided somebody with this stuff, with this paperwork, that they understand, that we've gone through all the steps. The only way for us to really do that is through documentation. Hi everyone, this is Mariam Treystman from the Home Health Consultant, and today we're going to talk about basic charting concepts. This applies to both home health and hospice. But first, if you like our content, please like, share, and subscribe. So let's start. Basic charting concepts are basic. We are going to talk about this for people who are new to the industry or aren't really on the clinical end of things, but should have this information as part of their general knowledge. I think when you start in any kind of healthcare field, but especially in home health and hospice, it's hard to really find intro kind of information. The information that's out there seems to be like very advanced and for hyper specific cases. And so if you're just new to the industry, like maybe you're a new employee at an agency or something like that, or whatever, whatever the situation, it's hard to wrap your head around things without getting like individually one-on-one trained by someone. And to have an idea about basics of the industry is very important. And then of course you can get like your one-on-one training to enhance your knowledge, but just to understand these basics is critical. So today I'm going to talk about what goes in a chart. We're not going to hyper focus on any one specific thing, but just kind of list the elements, the big elements, the major groups of charts. So first and foremost, you have your consents and other legal and contact information. And the way we're going to approach this right now is probably like the life cycle of how a patient gets treated. That's the order that we're going to go into with this. And every treatment starts with consent forms. The patient has to consent to your treatment and to all the elements surrounding your treatment. And so sometimes you'll have like 10 pages or 15 pages of consent forms that are in the shape of a contract. Consent forms are essentially the contract between the patient and the group providing service, whether it's a home health, hospice, hospital, whatever. If you've had any kind of healthcare in America, you first filled out some kind of consent, whether you know it or not. That means that could have been, if you're in an urgent care, you might be like tapping some things on an iPad. The person, at the front desk is like, or dental, anything like that. The person is like, this is a consent to photograph. This is a consent to x-ray you. This is a whatever. Every industry within healthcare is going to have their own kind of specialized things that need to be in the consent for their compliance. Like in home health, we're not giving you consent to x-ray. We're probably giving you, a lot of other kinds of consents, but not like others that, for example, in the dental office or the doctor's office. So the first kind of section of your chart, especially if you're looking at a paper chart, and what I like about people who have learned through a paper chart or have ever seen a paper chart is that it goes into some kind of like flow and progression. If you're starting off on a software, it sometimes feels a little more jumbled. I think it's harder to learn. When you see a physical paper chart, you can conceptualize this better. So the first section is the consent, and that's the first part of any treatment. Yes, you have your referral that comes before the consent process, but to start the treatment, you need the consent. The consent will include all sorts of section, but when we talk about the consents and that section, it's not just the consent, aka not just the contract to start services. Yes, that's a big part of it. But we also have contact information for all of the people that are going to be involved in your care. This could be your family members, this is your pharmacy of choice, your doctor, and things like that. A lot of things can go into it. These are just some basic examples for you to understand what it is we're talking about. There are also going to be things like do you qualify for the service? So maybe a Medicare secondary payer form where it's like a decision tree of whether you qualify for Medicare services or you're covered under Medicare. This, while agencies still use this form and it's still important, this was a really big deal before we had this really complex eligibility system. When you would get a referral, go out and get a copy of like a Medicare card, the Medicare copy, maybe it was from the doctor or whatever, but the eligibility was harder to check. So you had to go through this kind of decision tree to understand if your services were going to get covered. These forms are still included in the consents, but it's a lot easier to see if the patient has Medicare and if the kind of Medicare, for example, or other insurance types that they have will cover the services. So this first section of things is just all of the legal stuff that needs to go in, including contact information and things like that. This will also include some kind of admission checklist. This is a checklist of all of the forms that need to be provided to the patient. And like the patient kind of like, or the caregiver, whatever, signs that they've received these forms. This is a big legality for the home health to cover their butts, or the hospice to cover their butts, pretty much because in this industry, if it wasn't documented, it wasn't done. And so we need to show in every instance that we've provided somebody with this stuff, with this paperwork, that they understand, that we've gone through all the steps. The only way for us to really do that is through documentation somewhere in the chart. And so most charts will start out with an admission document checklist. So that's kind of the first section. What goes into an admission package is a bigger topic and can be a book, honestly, but it is, and it'll differ from agency to agency slightly, but there are clear rules around what needs to be in consent forms. There are a lot of conditional deficiencies that can get tripped up if you are not using up-to-date consent forms and things like that. Part of our compliance service is to keep up-to-date documents for both home health and hospice. So this is very important. And if you are on the compliance service at the home health consultant, please make sure that you are using the provided forms to ensure that you are using the most up-to-date version of whatever it is you need to use. The next section of things we're looking at are the large milestone evaluations. This isn't like the physical therapy eval to start physical therapy treatment. This is the oases in home health, and I'm not sure what they're called in hospice. I don't know if they have a name, but like the comprehensive evaluations in home health and hospice. So if you're using physical forms, you might be using like MedPass or Briggs. It's those like 40-page documents for both home health and hospice where it's like a comprehensive evaluation, meaning it's an evaluation of all body systems and just capturing the clinical snapshot of the patient in that moment. These evaluations happen at specific times within care. In home health, you have it at the first visit, the initial evaluation, and then at the recertification, at the discharge, and also at any kind of transfer or resumption of care moments. When we did paper charting before the tech age, this had its own section. Now, along with these major milestone evaluations, you also have care plans. Every one of these, besides the transfer and the discharge comprehensive evaluation, should have an associated care plan with it. If you're in hospice where the RN is conducting this evaluation every other week, there will be an IDG care planning update with each one of those evaluations. That's why the rule is that the RN is evaluating this in hospice every 14 days and the IDG happens every 15 days. It gives you like 1 day to be able to meet and review based on the comprehensive evaluation. And so let's pretend we're in a paper chart and you would have Oasis, care plan, Oasis, care plan. That leads us to what the heck is a care plan? And a care plan is pretty much like, what are you going to do for this period of time? When you admit someone into home health or hospice, you are admitting them for a specified period of time called an episode. These episodes in home health are 60 days. In hospice, they are 2 consecutive 90-day episodes, and then they go into 60-day episodes. And so your care plan is going to cover the entire episode. The care, the actual care provided, might not extend through the whole episode. You might achieve your goals earlier and discharge early. That's fine. But you need to have a plan for the entire episode or the entire projected time of care. If you project the care to only be 30 days, that's fine. The care plan covers whatever it is you project. However, we do recommend that your care plan is going to cover, like the whole episode, because while you can attempt to resolve the issue in, for example, 30 days, you don't know how the patient reacts to the issue. So unless you're there for something really specific, like IV antibiotics for 10 days, and there's nothing else that you're working on in this treatment, your care plan will probably cover the whole episode. Otherwise, you have to make new care plans and new evaluations every single time. So it's a whole mess. But anyways, we don't need to talk about exceptions. Let's talk about the rule. The care planning needs to cover the patient status, the physician orders, and the goals for that episode. Now, the next kind of section is any change to that care plan becomes a physician order. Of course, before starting treatment, there's always a referral. That's your first MD order, first and foremost. And so in the MD order section, you have the referral first. Usually the face-to-face document lives in this section. Any kind of additional orders. If you are in hospice, you might have the POLST in there, what happens if they, do you need to resuscitate, things like that. But pretty much, besides these standard forms, any kind of change to treatment is going to be covered by physician orders. While, especially in home health, you're kind of an unsupervised company in that there's no physician on site. In hospice, it's a little different. You have a medical director. That medical director is a kind of employer, contractor of your company, and they manage the overall care of the patient. And of course, the program, but it is the doctor who is managing the patient's care. The patient's care can also be managed by their primary physician, but again, we're going into too much nuance and detail. In home health, you don't typically have this kind of doctor on board managing care. The care is managed by the patient's primary physician or whatever specialist or hospitalist or whatever referred them to you. And so when you have your care planning process, this is essentially the doctor's kind of telling you, the doctor's direction of how to treat the patient. While you don't have in home health the doctor at the office managing the whole care, every individual physician that is referring and directing care is the boss of that care. And the care plan is their directive to the whole clinical team. The care plan needs to be followed meticulously. Any non-compliance to the care plan is a big problem. And so there needs to be a physician order there that is justifying it, explaining it, or changing it, whatever. The doctor needs to be aware and in charge of the care at every step. This means that you have to do everything on the care plan, but also you can't do anything that's not on the care plan. And this is a very critical concept. And so when people are chart checking, it goes like this. I'm going to speak in home health terms. If you're in hospice, just translate it to that equivalent. OASIS, okay, or whatever. There's a comprehensive evaluation. It's the description of the patient, right? That needs to correspond to the care plan. That needs to correspond to the care. Another element of the comprehensive evaluation, and like a critical element, is the medication list. This is part of your comprehensive evaluation. If you were to have a paper chart, the med lists live in a separate section. Any change to the med list, not the list, but like any change to the patient's medications needs to be reflected in the medication list. The medication list lives in several places. You need to have this medication list as its own kind of like drug regimen review form, its own form. That same exact list needs to live in the patient's home in their home folder. It needs to be in the care plan, and there needs to be a separate MD order verifying it. So let's talk about why it's in 100 places. But first, it's important to note that all of these places need to match. When you go see the patient for a comprehensive evaluation, when the RN goes and sees the patient or whatever clinician, they look in the patient's home and write down all medications that they can find in the patient's home. We can do a different video or article about like how to do this process, but pretty much you have to list every single thing you find. Eye drops, it doesn't matter if it's over the counter, it could be like vitamins, whatever it is. If the patient has it in the home and they should be taking it and are taking it, it needs to be on your list. If they're not taking it, it shouldn't be in their home. I mean, of course there could be like some kind of like vitamin that they're, for some other family member. We're talking about like for that patient specifically. Yes, other people will live in the home and their meds will be there too. You don't have to list their meds. But for that patient, everything for that patient lives on that medication list. Once the clinician writes it down, they need to contact the physician and read the whole list to the physician. That is what goes on the MD order. And it is part of the admission MD order. This order covers you for the treatment of the initial visit. So how MD orders work. The first MD order is the referral, and the referral allows you the evaluation visit. From the evaluation visit, that MD order, that first MD order, allows you to begin the treatment, because you might not have a care plan for a few days, but you might need to start sending other visits. For example, if you have another discipline on the case, they need to see the patient within like 48 hours. You might not have a care plan within 48 hours of the initial visit, and you get in home health 5 days to produce a care plan. For the time between the comprehensive evaluation, the first admission visit, and any additional visits in those 5 days that there's no care plan, that MD order covers you and needs to include the full med list. Every detail of that list, and what that MD order is saying is that you have spoken to the doctor, you've explained the patient's condition, status, whatever to the doctor as you found him at the evaluation. You've read the entire medication list. Any discrepancies have been resolved with this doctor, and the doctor has verified and read back the medication list. All of this is documented in that MD order. It's like a page plus at that point. From there, you create the care plan. Or, the care plan is not you, but like the care plan is generated. That med list lives on the care plan also. With hospice, sometimes you'll have forms where it's like a care plan and they say see med list attached, things like that. And the paper forms for hospice I found don't always have space for meds. But the 485 form for home health, the care planning form, does. And so that same list that's on your med list, that's on your MD order, also lives on the care plan. From there, Any change encountered throughout the episode to any medication is recorded in both an MD order, where you have to explain the change, and also updated on the medication list. This medication list copy also has to exist at the patient's. And so typically you will be notified of medication changes by finding it in the house. When you go to the patient, they go, you know, every visit should include, hey, have there been updates to your meds since the last time I saw you? And as a best practice, but also this is one of those best practices that should be the rule. The nurse, any nurse that's going into the patient's home should reconcile the medication list every single visit. You're just going to run into a lot less issues like that, especially because there might be multiple people managing the patient's care. The patient might not be all there, mentally, emotionally, due to diagnosis, due to medication that makes them drowsy or, forgetfulness, all sorts of things. And so when you're asking the patient and maybe whatever caregiver is there, they might not be aware of the dosage changed for this medication, or whatever, or there's a new med. And maybe the person that's aware is some family member that doesn't even live with them, or a neighbor. So asking is not enough. You need to check every med every time. If you see changes to the medications that are different than what's on your list, it updates in the patient chart, in the patient home folder, at that moment. You call the doctor, you verify there. Best practices, you also verify with pharmacy, by the way, this whole list, and make sure that they don't have any medications that the patient misplaced. I forgot, it's in my drawer, whatever, So you verify best practice with the pharmacy too, but it's not fully required. And so if you see a change to the medications on the list, you have to call the doctor's office and confirm. Because it could be a mess up from the pharmacy. It could be, changed already again. Who knows? You have to confirm it or it could be a different doctor prescribing that the physician who is managing your care is not aware of. Whatever. You have to just every time you call the doctor and you confirm. Every time you do that, that's an MD order. Then, of course, you call the agency and let them know. And that update gets recorded in the agency's medication list as well. You are not updating the actual form of the care plan because the care plan updates are the MD orders. MD orders are essentially addendums to the care plan. So the next section is going to be the visit notes by discipline. So in a paper chart, this would lay out like this. Every discipline would have its own sections. Every visit that is done for each discipline has an accompanying visit note. To understand how this works, you need to understand the life cycle of treatment. Regardless of what discipline we're talking about, except home health aid, you are always going to have an evaluation, some notes, some visits in between, and a discharge. Some variations could be evaluation, visits, re-evaluation, visits, discharge. Other variations could be evaluation, discharge. Another variation could be evaluation and discharge, one visit, anything like that. But you start with an evaluation and you end with a discharge. In between, you could have visits, you could have a re-evaluation, you can have nothing. But every single visit is going to have a visit note, because if it wasn't documented, it wasn't done. The nursing section, typically, you're just going to have visit notes, because usually if you have nursing on the case, the initial comprehensive evaluation and the final agency discharge, meaning the admission to the agency and the discharge to the agency, and any recertification in between that extends your treatment period to the next episode, will usually be done by the nurse or the nursing staff. For all the other disciplines, you have this eval, visit, discharge, life cycle within their section. The only exception to this is going to be your home health aide, because they are not able to conduct evaluations for themselves and are like a subsection of nursing, even though it's not really nursing, it's personal hygiene and kind of personal care, but it lives somewhat under the nursing umbrella. If nursing is non-existent for the care of the patient, you don't send it out just to supervise a home health aide. But you can't just have a home health aide or just have a hospice aide. Like, you can't only provide that service. You have to have some kind of clinical service accompanying it. And so whatever that clinical service is that's accompanying it will be the supervision for the home health aide or the hospice aide. And so the home health or hospice aide, which is essentially a CHHA, a certified home health aide, working in home health or in hospice, they are just going to have their visits and supervisory like notes and visits in between, but they're not going to have an eval and a discharge. The eval for that discipline happens at the time of admission or, whenever that service is initiated, but it happens by an RN or a physical therapist. It doesn't happen by a home health aide. So in every other discipline, you're going to, like, for example, let's say you have a case and it has nursing, physical therapy, and home health aide. Probably the nurse is going to be the one admitting to care, so doing the start of care. They will probably be doing any recertifications that might happen, and they'll probably be doing a discharge. And so the nursing section is going to have just visits, like a 30-day progress summary, whatever, like any ancillary paperwork. But like for the most part, it's just going to be the visits in between, because the admission and the discharge, the evaluation, the discharge are covered by like the general evaluation to the agency and the general discharge from the agency. The physical therapist is going to have their eval, visit, and discharge in the physical therapy section. So that's how it goes with all the disciplines, whether it's home health or hospice. Their evals and discharges and all the visits in between are going to be in their little section. The home health aide, again, is just going to have visits in there and supervisory visits, things like that. But anyways, the point is, every discipline has their own kind of visit notes that they need to produce. Then you have usually kind of a section, whether it's online software or like a chart, where you have miscellaneous stuff. If there are any labs ordered, like, okay, the patient's on Coumadin, you need to have, or, whatever, you need to have labs occasionally to make sure that they're not going to like bleed out if they have a cut, things like that their blood's not too thin. And so let's say you need a weekly lab. That's going to live in that miscellaneous section. Other things that can be in that section is like medical history from the hospital that's like 40 pages long, and things like that. Like just any kind of random outside information that's not the care you're providing, but just like outside information that you're receiving from other places and things like that. It's just literally miscellaneous stuff, not your care. And then you have the discharge. The discharge is when you say, no more treatment for this patient, this is the last day, blah, blah, blah. That is usually accompanied by a comprehensive evaluation, which is a snapshot of the patient at the last visit. It's either the discharge date or the last kind of, just based on the last comprehensive evaluation of the patient. Not to get into too many like exceptions and details, usually when the patient is being discharged, an RN or other clinician, evaluation level clinician, will go out and complete a comprehensive evaluation, capturing their snapshot. If it's a goals met kind of discharge, meaning like you've met the goals, there's no more treatment necessary, then they're doing a visit to make sure the patient is okay, there's nothing else needed, like they're good for discharge, they're going to be safe in the community. That's for home health. And for hospice, of course, it's a little bit different. Most of the time, and should be all of the time, but most of the time, the hospice discharge is death. So you're going to have a couple of forms describing it, but it's not going to be some 50-page document. But the discharge is a event in time that you need to capture specifically, and will have its accompanying forms depending on why there's a discharge or what's happening and things like that. A couple of other elements that you should be aware of is a transfer, meaning the patient transfers out of your care. This often happens for hospitalization. So let's say the patient goes to the hospital. In home health, you're doing a transfer oasis, similar to hospice, but you shouldn't be transferring them to hospitals all day long because it's just not part of what hospice should have. But transfer means, hey, this guy's in some other medical facility or someone else is taking care of them for some period of time. We are not responsible for this care at this moment. When they come back, that's called a resumption of care. Now, this means that they went away for some time and now they've come back. The resumption of care requires its own comprehensive evaluation. Whether they've transferred out for 2 days or 2 weeks, you still need to reevaluate that patient, because in those 2 days, they might have had a heart attack and their whole condition is different. So you're really doing another essentially comprehensive evaluation, and any kind of comprehensive evaluation that's not a discharge has an associated care plan. So that's it for basic charting concepts. Of course, there's a lot more in-depth information. This is just an intro for if you've never seen a chart before, are kind of confused about what goes in one. We do have a much more comprehensive training within our compliance program, kind of going over in more detail what all these things are, exceptions, and things like that. But for the purposes of a quick podcast, this is basic charting concepts for home health and hospice. Thank you so much for tuning in. And of course, if you like our content, please like, subscribe, and share.